Do you think the way that the CMS has structured the product categories would serve as a significant disincentive to small firms conducting research and development in new medical technologies?
Well, I think that it probably goes back to some of the comments earlier on around if we're really paying for a low bid, right? We're paying for the lowest price. We're not paying for an outcome. In many cases, there's not even really good clinical data to support the efficacy of that product. As Mr. Wilson said earlier on, that some of those products are 510K approved, which means that they just need to prove that they function. They don't have clinical studies behind them to show that they're efficacious or that they're clinically capable. So I think what happens is you end up getting a low price issue. So, the companies now try to, instead of developing new technology that's moving us forward in healthcare, you're going to develop very, very inexpensive products that we can deliver for less than anyone else, but don't have good long-term clinical outcomes. And I think that's the direction the free market economy will take you in that at that point in time.
What impact do you see or foresee CMS's program have on the technology innovation in medicine?
I think that that's probably one of the most critical aspects is that, and we look at it in pharmaceutical and medical devices alike, it's very expensive in today's day and time to develop products, to do the appropriate clinical studies and trials that are required to get a product on the market and make certain that they're moving healthcare forward. I think, again, when you shut down some of these small companies, as we said, ours was a small startup from Dr. Jim Leininger, an ER physician 30 years ago, and it's now a $1.5 billion company. So I think some of these startups won't have the opportunity really to get their feet off or get off the ground, and that's very unfortunate in this environment.
Mr. Sutton, you were telling me that you had beneficiaries who would call you at 1 o'clock in the morning. Why do you service? I mean, why don't you just tell them to call 911?
Well, Congressman Shuler, thank you for the question. Our business is 24/7, 365, and that's, oxygen is vital for folks that are chronically, hypoxic or low oxygen in their blood. So that's our job, and it's service based, and we are on call, and that's what we signed up to do, and so that's why we're in the business we're in. And what frustrates me, an example I'd like to elaborate a little bit on, is skilled facilities in our area in Western North Carolina frequently have contracts with companies in Virginia and Tennessee and different areas, and we routinely get calls from these facilities that say, this patient's qualified for oxygen, or they've moved into our skilled facility and need a continuous positive airway pressure machine for sleep apnea. And the company that we contracted with, it's going to take 2 or 3 days to get the equipment. That's the comment we get from them, and so they want to pay us for a couple of days of service. And if of course we graciously go and help them out because we got to help patients, and that's what we signed up to do, even though we don't have that contract. But those are instances where those folks, if they don't get the care they need, 2 or 3 nights without a sleep apnea machine, they could have a stroke. A week extended stay in a hospital, patients that can't get oxygen on time. If we don't take those calls at 1 or 2 o'clock in the morning, and the patients are elderly, they live home alone, they can't change a tank with a power out because they don't have the strength to do it. So if we don't make that visit out there to either change a tank or help that patient, they call 911, and they've spent $4,500 of Medicare beneficiaries. There it is. They spend money in the hospital and make frequent visits to the physician's office. So, those are some unintended consequences that, I request that you folks really look at and pay attention to. And I urge CMS to not just assume that, we may save 26% up front, but what's going to happen, a month into the program with these folks with disruption in service, the unintended consequences. I can't implore enough on you to research before it happens.
And I'm sure you get paid extra after hours, after 10 o'clock at night, you get paid extra.
Congressman Shuler, I think that's an interesting question, in that earlier the gentleman from CMS said that we get approximately $300 a month, and it's somewhere around $239 to be exact. And that's if you don't get a call from the patient, or you don't have to deliver supplies, or you don't have to go out there to see an elderly patient with chronic lung disease that has a lot of anxiety. They're
So do you get paid more every time you serve?
no, those are free visits.
So it's a
We
free
can't-
visit to you?
You know, and
What's cost?
Gas is now $4 a gallon in rural Waynesville, North Carolina. So, you know, besides my cost of my driver, my technician, and the time away that he could be doing other things, that we're there, and that's not included in the cost.
What's the distance between your Waynesville location and the longest distance you'd have to travel to service a patient?
We serve Haywood County west all the way to the line, which is Robbinsville, Murphy area, Graham County.
So 2 hours?
2.5 hours, and
Drive.
we are on call. And it's it's not like a major interstate highway, Congressman Shuler. You know that as we drive through Swain County, it's it's
We're working on that intent.
winding road. So it's a lot of cost, and those are things that again I implore CMS to consider that as it. And we, I'm in Waynesville, North Carolina, and Asheville is 25 miles from my area, so I'm going to assume that my zip codes will be included, and that's not been released yet. So.
Mr. Hite, how far is your furthest distance, or would you like to comment based upon the question?
It's very similar to Heath's situation. We have patients that far away. Now, obviously, it's discretionary. I mean, we could choose not to accept a patient that lives long distances, but we often do because there's not. It's the physician's choice. Physicians are referring the patient to us for a reason. Ultimately it comes down to the patient, but the physician is saying, hey, this is who you need to deal with because they provide this specific product and it's going to improve your life. So in those cases, we accept patients from long distances and travel those long distances. And to Heath's point, you're not just paying $4 a gallon in gas, you're also paying overtime to an employee to go out in the middle of the night. We'll continue doing that. It's just the ethical thing to do. I don't know whether to drive us out of business. It might under the new reimbursement schedule, but it's what's right.
Following up on your original question, why do we do that? In rural America, that customer is not only your patient. You live with him. Right. You live with his family. You have to face him every day. So every decision you make, you have to deal with the consequences of that decision on a daily basis, good or bad.
Absolutely. Well, I commend all of you for that. At this time, Mr. Gonzalez, if you have any questions.